So, ladies and gentlemen, welcome to those of you who are here in person, IRL, and those who are joining us on Zoom. Welcome to all of you. And here we are celebrating, can you believe it, the 3rd anniversary of the Daffodil Centre. It must feel like it's been a lifetime for many of you and like it was yesterday for some others. My name is Jacinta Tynan, and I'm so honoured to be your MC today for this event. We're going to be having the most wonderful discussions. But before we begin, I would like to welcome a really special guest, a young Wiradjuri woman, Savannah Fynn, who is going to do a welcome to country. Savannah.
So good afternoon, everyone. My name is Savannah Fynn, and as you all just heard, I'm a proud Wiradjuri woman. I'm originally from Dubbo, New South Wales. I'm currently in my 4th and final year of a Bachelor of Social Work, while also working with the Metropolitan Local Aboriginal Lands Council, going out to sacred sites with youth and making sure they're maintained and untouched. So before I give a welcome to country, I would also like to acknowledge both past and current representatives of Metro Lao for the cultural knowledge, wisdom, and words that they've taught me and passed on to me and that I speak of today. So I'm the first youth representative of the Metropolitan Local Aboriginal Lands Council and have the cultural authority and endorsements under the Aboriginal Lands Act for the lands we meet on today. It's important to acknowledge the nation's boundaries covers the Hawkesbury to the north, the Nepean to the west, and the Georges River to the south. The landscapes on which we meet on today are defined by the hills, mountains, and waterways, which were created during the dream time. A welcome to country is not just a bunch of words, but is spoken from the heart. And in doing this, creates a cultural, safe, and spiritual environment where everyone is able to take a moment to themselves to connect and ground with Mother Earth. I would like to pay my respects to all elders, past, present, and emerging, and extend that respect to you all here in the room with me today. So on behalf of the Metropolitan Local Aboriginal Lands Council, board, members, and especially our elders, I would like to welcome you all to the lands of the Gadigal people of the Eora Nation. Welcome, welcome, welcome. Thank you so much for having me.
Thank you so much, Savannah. It's extraordinary watching you just speak from the heart like that. It's wonderful to see, and I'm sure everyone wants to wish you all the best with your endeavours, seeing as you're just getting started. Thanks for being with us, but you're welcome to leave whenever you need. No pressure. So as we mentioned, I know you all know the Daffodil Centre is celebrating its 3rd anniversary. This is a very special event to mark those 3 years. As you know, and if you don't know, the Daffodil Centre is a unique joint venture synergising the cancer research strengths of its 2 partners, which is Cancer Council New South Wales and the University of Sydney, where we are standing this afternoon. Cancer Council New South Wales is Australia's largest non-government funder of cancer research, with a history of leading in cancer epidemiology, integrated with the organisation's advocacy and its prevention, and really importantly, which we're going to talk about today, patient support programs. And the University of Sydney, if you didn't know, is Australia's oldest university with a prestigious world-leading faculty of medicine and health. So the goal of the Daffodil Centre is to leverage these combined strengths and publish research that is designed for rapid translation into policy and practice to produce the largest measurable improvements, very important, isn't it, in cancer outcomes. Recent successes in informing policy decisions and guiding best practice in lung cancer, bowel cancer, breast and cervical cancer screening exemplify what the work that you do here at Daffodil, driving change in Australia and supporting Australian international leadership. So last year's 2nd anniversary, the event then focused on the centre's work in shifting the dial in cancer control, projects that have the greatest impact measured in reduced cancer incidence and mortality and system-level change to improve outcomes. This year, we're shifting the dial again, and the focus is on the importance of engaging with community and with individual consumers to continually improve the prioritisation and effectiveness of the research done here. So the recent establishment of a new consumer engagement panel, which we'll be talking about today, which has linkages through its members with a wide range of stakeholders, will help to strengthen Daffodil's relationship with consumers and community. So today's event, including a panel discussion, which the title is Involving the Community in Our Research, will showcase how the Daffodil Centre is working to strengthen our engagement with consumers and the community more broadly in the design and delivery of our research as we reflect on 3 years of the Centre's research. So that panel discussion will be in a moment. We're going to hear from a few really important speakers before that. And first of all, I would like to introduce Professor Sarah Hosking, who is CEO of Cancer Council New South Wales, known to many of you. But before she gets up, I'll just tell you, I mean, all of your bios, it's impossible to reduce, but I'm summing this up briefly to let you know that Professor Sarah Hosking was appointed as Cancer Council New South Wales CEO December 2021. She's brought to this role a wealth of experience in the health centre and executive leadership, most recently leading the National Breast Cancer Foundation. And of course, she has a strong medical background as a researcher and a clinician as well, which she brings to this role. Please welcome Professor Sarah Hosking, dressed very appropriately like a daffodil.
I think, Jacinta, you and I are top and tailing the daffodil. You're the leaves and I'm the flower. So thank you, Jacinta, for such a warm welcome. And I know she's just left to go and do her studies, but also wanted to acknowledge and thank Savannah for that lovely welcome to country that she shared with us. I'd also like to start by acknowledging the traditional owners of the lands on which we meet today, the Gadigal people of the Eora Nation. I pay my respects to elders past, present and emerging. And also reflect on those of you who are not on Gadigal land, so particularly the people online, and extend that respect to everybody that's listening in today. I'd also like to thank a few people who make all of this possible. The Centre's work, it's a huge investment. It's so many people, so much passion, and a lot of dollars too. So there's a lot that goes into it. So I really want to reflect and just thank our many generous supporters and donors. And also just to call out a couple, the Fussell Family Foundation in particular for their support of the ovarian cancer research stream within the Daffodil Centre, and also the Minderoo Foundation for funding the Elimination Cervical Cancer in the Western Pacific initiative, which is a really important initiative of the Centre as well. So some really amazing support that we have across the board. And we'll be hearing more about some of those streams a little bit later on. It's an absolute privilege to be here today, marking, as you've heard, 3 years. It seems like 5 minutes, Robyn. It's 5 minutes, isn't it? And it seems a lot longer some days, and sometimes a lot shorter, as you've alluded to. And that's our official history, and the many conversations that happened with many people prior to that. But it's been an amazing journey, and it's wonderful to reflect on where we've come from and where we're headed. And we have a really important theme today, as you've heard, standing side by side, involving consumers in our research. It's fair to say that consumer involvement isn't new. I mean, this is something that has been going on for some time. And the research community has really been engaging quite closely with consumers for a number of years. And they've definitely reaped great benefit from listening and engaging with those stories and ideas from consumers. But we do still have a lot to learn, and we need to reflect on how best to support those cancer consumers and how to apply their invaluable perspectives and insights into the research that happens in the Daffodil Centre and elsewhere, so that we can really achieve the best outcomes and the best impact as well. In the 3 years since the Daffodil Centre started, and this is a little bit staggering for me to think about, but since we officially launched 3 years ago, 450,000 or thereabouts Australians have been newly diagnosed with cancer. That's enormous, a huge number of people in such a short period of time. And let's not forget that while they are cancer consumers, their friends and loved ones are also cancer consumers. So many people are touched by the disease. It's also true that the extent to which people affected by cancer achieve and get the support that they need. It is very varied, and not everybody gets everything they want from their cancer journey. We, the Cancer Council and the University of Sydney, through the important work of the Daffodil Centre, are here to stand with all of them, whatever their background and wherever their journey started and wherever they are headed. While engaging with and hearing the voice of consumers and community is the theme for today, for the Cancer Council New South Wales, it's also been quite a key part of the newly launched 5-year strategy. So it's something that's very much at the forefront of our minds. For the Cancer Council, this engagement will be the key to how we deliver on the various strategic initiatives and objectives that we are focused on. So, of course, reducing cancer risk, increasing cancer survival, improving the quality of life for people affected by cancer, and achieving greater equity in cancer outcomes. And that's a really key one, and not always the easiest one for us to achieve, but something we're very focused on. There are some important mandatory requirements around engaging consumers in research, such as their representation as investigators in research programs, but also participation in a range of areas, including clinical guideline working groups, grant review panels, ethics committees, and a number of other ways as well. So it's a very, very diverse role. We ask a lot of our consumers, and we receive so much from them in doing so. But our goal here is not about complying with mandatory standards. Our goal is really about how we can look at those requirements and really raise the standards and set the standard so that we do the very best we can to make sure that they are heard and that we listen. To this end, the Daffodil Centre has established a new Consumer Engagement Committee, which will be chaired by Mr. James Butler OAM, who is here with us today, and you'll be hearing with him a little bit later on. James is a long-standing friend of the Cancer Council New South Wales. He was on our board for many years and only recently stepped down just before Christmas. He was allowed to retire at long last. But he's also one of the country's most experienced and devoted consumer advocates. So we're really privileged to have had this journey with James, and I think the Daffodil Centre is very fortunate to have his engagement going forwards. The new working group will help to ensure that the Daffodil Centre goes above and beyond standard practice in consumer engagement. And in the spirit of research and innovation, it will promote new and better ways to embed consumer experience in everything that we do. Stronger engagement with consumers has never been more important than now. We can only get this right if we talk to them and if we listen and if we engage in new ideas that come from them. At last year's 2-year anniversary event, I cited the Daffodil Centre research that predicts that 4.5 million people, or thereabouts, will be diagnosed with cancer in Australia between 2020 and 2044. 4.5 million people. It's huge. Every one of those 4.5 million people has their own unique story of cancer. They have stories of individual and complex support needs, and they're going through what for many of them will be some of the most difficult times in their life. With 4.5 million new cancer cases over 25 years, there are huge challenges for us all to contemplate from every component of the research spectrum in cancer. Everything from prevention, screening and early detection, clinical and supportive care, to quality of life and long-term survivorship. Collecting new evidence on all interventions will be the key to improved outcomes. At the Cancer Council New South Wales, we're very proud to be the only charity that works across all areas of cancer control, all cancer types, and for all people affected by cancer. It gives us a perspective on how these sometimes seemingly separate but overlapping pieces interrelate to a cancer control continuum, but with consumers at its absolute heart. This will help to ensure that evidence can be rapidly translated into policy and practice and can drive system-wide change, which is the only thing at the end of the day that's going to change the stats. This celebration today provides an insight into how we are improving and engaging with consumers as we reflect on the 3 years of Daffodil Centre research. I close by congratulating you, Karen, for all your work and the team as well. Absolutely phenomenal work over the last 3 years. And I wish you all an excellent afternoon. I think you're going to really enjoy the stories that we're all going to hear. So thank you.
Thank you so much, Professor Sarah Hosking, and really staggering statistics there, I have to say, but it's also so encouraging to know that your centre here really advocates for the consumer in the numbers of cancer patients that you're predicting there. Now I would like to introduce Professor Robyn Ward AM, who is the Executive Dean and Pro-Vice-Chancellor of the Faculty of Medicine and Health at the University of Sydney, which she's been in that position since 2018. And she is also an academic leader, cancer researcher and medical oncologist. Please welcome Professor Robyn Ward.
It's great to be here. I was just trying to think of the theme. So I guess on the sort of pale sky or something on the yellow and green. Sorry. should have dressed for the occasion. I would like to also acknowledge that we're meeting today on the lands of the Gadigal people and pay my respects to elders past and present, and also those in the audience who are First Nations people. It's a great pleasure to welcome you to the Susan Wakel Health Building. This is a building that is created to train the next generation of health professionals, and I know that means a lot to perhaps everyone in the audience, but also to many people who don't realise how important it is that we continue to train people working in all areas of health, not just in cancer. The building was built as a consequence of a generous donation from the Isaac and Susan Wakel Foundation, and Susan Wakel decided to donate the money for this building because of the care she received from nursing during her illness. So she didn't have cancer, but she appreciated the care, the palliative care that she got from the nursing community, and felt she wanted to reinvest. So it shows you that this continuous cycle of gratitude does pay forward, and a lot of nurses will be graduating as a consequence of her generous gift. The final thing I just want to say by way of introduction is on the way out on the left-hand side, or the way in on the right-hand side, you'll see a dilly bag made by Judy Watson, a great First Nation sculptor. And this is the site of healing and a birthing site for First Nations people. So again, it has a lot of importance to the university and to our faculty in particular, and perhaps to many people in the audience who now work with us here at the University of Sydney. So as Sarah has said, it's been wonderful to have Sarah as a partner in this initiative. It's 3 years. That seems like a very long time, as Sarah said, and sometimes like a very short time. But the consequences of forming the Daffodil Centre, which is a partnership between the university academics and Sarah and the Cancer Council, has really been to bring focus to policy and advocacy and addressing inequities in cancer care. And I don't think any other centre across Australia has really dedicated itself to that particular part of cancer. There's lots of cancer centres working on fundamental discoveries and new clinical trials and other things, but this is a centre that is uniquely placed, I think, to address what is often a very forgotten area, which is around inequities in cancer care, advocacy and changes in policy which are needed if we're going to move the dial on cancer outcomes for everyone, not just for a few. Advocacy is a terribly important component of delivering any research, and I just had the sort of pleasure of reading a long document that I was asked to review the other day from our NH and MRC around how to better engage consumers in research. And it's interesting because as an oncologist for 30 years now nearly, it is amazing how long in oncology and in cancer care that consumers have been so woven into everything we do. But I can see that in many other areas of medicine that hasn't occurred, and as a consequence, I don't think the impact of their research has been as transformational as perhaps it could have been if consumers were involved right from the beginning, from the design of the studies to helping those studies follow through the path of translation and then advocating for their uptake into the health system. And there have been a huge number of patient consumers. I won't try and name them all now, but many of you, particularly working with the Cancer Council, will know their names, have been extraordinary advocates for cancer care in our community, and I think have left a lasting legacy. So have many clinicians. People like Tom Reeve and Martin Tattersall were very early adopters of the idea that you needed to get cancer guidelines updated with information that was relevant to consumers, and they involve consumers in the construction of those clinical guidelines. And it seems like that's pretty obvious, but this was like 30 years ago. So this was way ahead of the game. They were already doing these things, and I think they pay a lasting legacy for everyone. Now, I wanted to just say a couple of words about the Daffodil Centre. You've already heard a little bit about it, but Daffodil Centre is organised into 4 hubs and a lot of cross-cutting themes. They've got a lot of engagement with various networks, including Sydney Cancer Partners, which is an important network for the Daffodil Centre. They spend a considerable amount of time developing some very robust methodologies and methods, which not only are important for the scientific community, but are also important for convincing government whether certain interventions should be adopted into policy. Without that evidence base and the strong methodology, it would be impossible to get many of these things into practice. But unfortunately, as Sarah has told you, more and more people will have cancer over the next few years than we would like. One day we would like zero cancer. I guess that will be a long time coming, but hopefully we continually reduce the deaths from cancer. But we know that death rates from cancer are not being reduced equitably across different demographic groups. And a case in point is liver cancer, which has risen over the last 2 decades and continues to rise, largely because the cancer affects particular demographics of our society, Indigenous people, people who are migrants to Australia, often because they are co-infected with hepatitis B or C, and that predisposes to liver cancer. So it's wonderful to see that the Daffodil Centre is picking up that issue. They were funded by the Australian government to pick it up as an issue, and hopefully that through their efforts and the efforts of others, we'll see the outcomes sometime down the track that look very much like cervical cancer, where we might be waving goodbye to it in the rear vision mirror and no one talking about it anymore. So I'm sure that for cancers like liver cancer, this is also an achievable goal, and we really need to ensure that we're working with the communities that are very heavily impacted by this particular cancer to make sure that all the interventions that could reduce the impact and eventually solve the disease are brought to fruition quickly. So finally, I'd like to thank Karen, Canfell and Anne Cuss for their leadership of the Daffodil Centre. I won't name all the theme leaders and the cross-cutting people because I'll get your names all wrong, but I just wanted to congratulate everyone on 3 years and wish everyone a fantastic afternoon and enjoy all the seminars that will be presented. Thank you very much.
Thank you so much, Professor Robyn Ward. And I, when I was doing this event, emceeing this event 2 years ago, I remarked on this and I'm remarking on it again. All these women in power here, all these women facilitating great change and research is just wonderful to see. And there's more to come. So now, speaking of which, I'd like to introduce Professor Karen Canfell, who is, of course, the director of the Daffodil Centre. I'm going to tell everyone a little bit about you, Karen, before you get up, even though most people are familiar with your work. So Karen, of course, is the inaugural director of the Daffodil Centre. She's also a professor and NHMRC Leadership Fellow, Faculty of Medicine and Health at the University of Sydney. She's an epidemiologist and cancer researcher whose research involves evaluation and translation of new strategies for cancer control. And she's led multiple projects for government agencies in Australia and internationally. Her research over the last 20 years has had a major impact on cervical cancer prevention policy decisions in Australia and globally. Karen and her team led key aspects of the World Health Organization strategic plan for cervical cancer elimination and development of new global guidelines for cervical screening. That's just one thing that I plucked out of her extraordinary career thus far. Please welcome the woman who is known to many of you here, I know, but Karen Canfell.
Thank you so much, Jacinta. And I just actually want to take a moment to acknowledge Savannah's wonderful welcome from the heart and also pay my respects to the Gadigal people of the Eora Nation on whose lands we meet. So it has been an extraordinary 3 years, and thank you so much, Sarah and Robyn, for sharing your perspectives on behalf of Cancer Council New South Wales and the University of Sydney, respectively. And on behalf of all of us at the Daffodil Centre, I really want to express my great appreciation to you and your organisations for the support, the ongoing support that you've given us in establishing and building the centre over this 3-year period. And this extends to senior management at the University and the Board of Cancer Council New South Wales, and particularly you and the other members of our Joint Steering Committee. We're also very grateful to our philanthropic research funders, whom Sarah also acknowledged. I want to also take this important opportunity to acknowledge and thank our Daffodil Centre staff, both academic and professional, for the outstanding efforts over the 3-year period, and to thank Anne Cust and Karen Hill for their co-leadership in building our centre, as well as our research steering group, who've provided so much input and guidance to the building of the centre. And also not to forget to thank the organisers for today's event, Caitlin Ward and Millie Hanlon and the working group, and the wonderful Sandra Deborach for all your support. So the Daffodil Centre's strategic focus, as you've heard, is research targeted at translation into policy in practice in ways that deliver the most impactful outcomes for our community, which takes us to the theme for today's celebration, involving consumers and the community in research. At the Daffodil Centre, as you've heard, we do stand side by side with the community in the research that we do and in the translation into policy and practice. And this really is an enabler and plays a key role in making sure that equity is a cross-cutting theme in all that we do as well. So as Sarah alluded to, one of the developments that we're most proud of this year is the establishment of the Daffodil Centre Consumer Involvement in Research panel. And this really builds on our previous record of consumer engagement at a project level, but it really systematizes and elevates this to really a integral component of the Daffodil Centre's involvement of the community in research. And I want to take a moment also to directly acknowledge James as the chair of the panel, but also the other panel members, Catherine Leaney, Carly Nielsen, Jeff Cuff, Victoria Turner, Jill Stannard and Christy Yu. And also to pay tribute to Lorraine Tyler, who sadly passed away earlier this year, and to extend our deepest condolences to her family. I also wanted to acknowledge the leadership in this space from Associate Professor Eleonora Folletto, who's coordinated this important panel. So as chair of our panel, James is now part of the Daffodil Centre's research steering group and has already been involved with panel members in research team day events and fora for researchers to present and obtain feedback on the various aspects of our work. And we're so excited that as we work together over time, our new panel will guide us to ensuring that we really embed consumer and community involvement into absolutely everything we do at every level as a centre. So I'm really excited that you'll shortly hear from a cross-section of our early and mid-career researchers and also from our panel members on some of the highlights and translational aspects of our work this year. And there are, I'm really pleased to say, too many achievements to discuss in detail, but I'm going to try and snapshot a few of them and paint you a little bit of a picture. There are a number of ways to measure success in research, and I'm proud to say that I think our centre is performing beyond expectation in all of them. A couple of things first that hopefully are self-explanatory. So in 3 years, we have published 475, just a tick off 500, peer-reviewed scientific papers in quality journals. Our funders include NHMRC, the Medical Research Future Fund, Cancer Institute New South Wales, Cancer Australia, National Cancer Institute USA, the Bill and Melinda Gates Foundation, Cancer Research UK, and the World Health Organization, as well as, of course, our founding institutions. And we have had success in 135 individual research grants and government contracts. Most importantly, though, beyond these scientific achievements, I'm so proud to be able to say that in only 3 years of operating, the Centre has already published research in many areas of cancer control, which when embedded into policy and practice will measurably result in lives saved, extended and improved. Building on the work that Sarah talked about, this year, just a couple of months ago, we published new projections. These new projections in Lancet Regional Health do show that without further investment and action, cancer is projected to be the leading cause of premature mortality in Australia, not just now, but over the next 25 years. That's more early deaths than cardiovascular disease, more early deaths than external causes, more early deaths than respiratory disease. However, this picture can change with increased investment in research and policy translation. For example, when I spoke at last year's anniversary event, I was really delighted to reflect on how economic and health services analyses published by our lung stream had been catalytic in Minister Butler's announcement and commitment to introducing a lung cancer screening program in Australia in 2025. Since then, Minister Butler has announced another landmark review of Breast Screen Australia, the National Breast Cancer Screening Program. And breast cancer screening has been a great public health success story. It's estimated to have reduced mortality rates in screened women by about a half. But still, breast cancer is the second leading cause of cancer death in Australia. And in announcing the Breast Screen Review, Minister Butler cited the findings of the Breast Rosa project, which was commissioned by the Australian Government and led by Associate Professor Carolyn Nixon and the Daffodil Centre's Breast Cancer Policy and Evaluation Stream. The Breast Rosa project is a major roadmap for the future, mapping out a path to risk-adjusted breast cancer screening, which is really a potential game changer in breast cancer outcomes. Furthermore, since last year's event, our gastrointestinal stream, led by Associate Professor Eleanor Filetto, has delivered NHMRC endorsed guidelines for lowering the recommended age for bowel cancer screening in Australia. And this is now a matter for detailed government consideration. And finally, this year, our cervical and HPV stream have directly supported the development and launch of the Australian Government's National Strategic Plan to eliminate cervical cancer in Australia by 2035, an endeavour that's fundamentally informed by our research. These areas of policy and practice have an important international dimension as well, and we collaborate increasingly with international colleagues in both formal and informal partnerships to share data and learnings and work towards global solutions to cancer control issues. Our work is helping to strengthen Australia's standing as a world leader in cancer control. For example, this year, our work supporting new World Health Organization cervical screening global guidelines for women in the general population and women living with HIV was published as a pair of papers in Nature Medicine. And just in recent months, Foreign Affairs Minister Penny Wong has announced the award of a new $12.5 million regional health partnership, the EPICC partnership, to eliminate cervical cancer in the Indo-Pacific, which will be led by the Daffodil Centre. To our knowledge, this is the largest Australian foreign aid grant ever allocated in cancer control and takes Australian leadership to a new level, notably with a focus on in-country partnerships and integrating technical expertise with local knowledge and advocacy. So the work I've talked about today and the work of all the Daffodil Centre streams is at the cutting edge of independent research and evidence review and is today informing major decisions in cancer control policy and practice. But at the core of this is effective community and consumer engagement, and that's crucial to everything we do and crucial to our plans to grow and evolve to meet the challenges of cancer control today and in the future. So in closing, thank you so much to all of you as key members of our community. Hand in hand with you, we can drive the changes in health policy and practice that are needed to improve cancer outcomes for all. Thank you very much.
Thank you, Karen, for outlining the just extraordinary work you're doing here at the Daffodil Centre. It's just stunning to hear of all of the work happening now and in the future. And as Karen mentioned, we're going to hear from some early to mid-career research projects that are going on. So we're going to hear from some of those medical professionals, just little short bites to tell us some of the work that is going on here at the Daffodil Centre. So first of all, Dr. Karen Chiam, who is going to talk to us about the global impact of COVID-19 pandemic on cancer care. She is from the Prostate Cancer Research Stream and International Cancer Benchmarking Partnership Project at the Daffodil Centre. Thank you so much.
Thank you, Jacinta. Let me just see, how do I navigate the slides? Oh. I don't think I need to give introduction to the COVID-19 pandemic to anyone in this room because we've all been through it and have been impacted by it in some way or another. The pandemic has an unprecedented impact on the health systems and cancer care globally, but this impact does vary across countries and even regions within a country. In addition, the cancer patients are considered an extremely vulnerable population during this time. And these are some example quotes from cancer patients in Victoria describing the fear and stress that they experienced during the pandemic. And these are findings from a previous research that is conducted at the Daffodil Centre in collaboration with the Cancer Council Victoria. We are also involved in a series of international work on COVID-19 and cancer care. In March 2020, as a rapid response to the pandemic, the EPICC Consortium was established, and it was previously known as the COVID-19 and Cancer Global Modeling Consortium, where the initial aim was to bring together the international modeling community to support decision-making in cancer control during the pandemic. But as you know, as the pandemic evolves, the situation has changes. So currently the consortium's objective has shifted to building resilience in cancer systems globally. This EPICC Consortium is co-led by the Daffodil Centre and the International Agency for Research in Cancer. And it also involves other partner agencies, including the International Union for Cancer Control and the Canadian Partnership Against Cancer. So the EPICC was approached by the International Cancer Benchmark Partnership, which I will refer to as ICBP from now on, to conduct this specific project with the aim to collate all the health systems and clinical policy responses in cancer care across the 10 participating countries in ICBP. So just a very quick introduction on ICBP. It is a multi-country collaboration that aims to measure international variation in cancer care and outcomes. And their ultimate goal is to really improve policy that can enable and enhance care and outcome in each of these countries. So for this particular project, we are focusing on the 10 countries that are noted in green and pink on the map that you're seeing here. Oh, that's not correct. Oh, I think that's this is supposed to be the last slide, but it's okay. This project actually involves a large number of both our internal and external collaborators. So it involves the ICBP management team, but also a lot of research fellows at the Daffodil Centre, the new university, as well as the international collaborators from the Canadian Centre for Applied Research in Cancer Control and the International Agency for Research on Cancer. So we have utilized 3 different approaches to collect a large amount of information on the cancer care scenario for each of these 10 countries in cancer care between 2020 and 2022. And the approaches that we've utilized includes desktop review of rare literature materials, and they are materials that includes things like government reports and clinical guidelines. And the 2 other methods that we have used are conducting surveys and interviews on the ICBP stakeholders, who are individuals involved in delivering the cancer care, as well as decision-making in each of these 10 countries. So in the interest of time today, I will just be giving a snapshot of some of the key findings from the stakeholder interviews, focusing on the common experiences that across the 10 countries. So in 2020, disruptions to cancer screening and PPE supply were identified as the most common issue faced by across the 10 ICBP countries. But there were also a lot of other notable and common mitigation strategies, including staff redeployment, centralized decision-making, and prioritizing services that enable services to continue. By 2021, the rollout of the COVID-19 vaccines was a key turning point for many of the countries. But at the same time, the countries are now met with new challenges, including increased wait times and backlogs, staff shortages, and burnout. In fact, by 2022, staff burnout remained a very persisting and common issue faced by many of these countries. But at the same time, there were a lot more reflections on the key learnings and perspectives of what strategies have worked and not worked for each of these countries. So currently, our team is working very closely with ICBP and the stakeholders to share and discuss our overall findings. I guess one of the key goals that we're working on right now is to identify the potential recovery actions and plans to address some of the key persisting issues like the staff shortages and burnout that we've identified through our work. At the same time, we are also working very closely with the International Agency for Research on Cancer, who is working on a separate but complementary piece of work, looking at the impact of the pandemic on cancer incidence and mortality through cancer registry data from the 10 ICBP countries. So our study findings will be very crucial in assisting their team to interpret the registry data. And we are at the wrapping up stages of our project, and hopefully we'll be able to share more findings to the wider community in the next few months. Thank you.
Dr. Karen Chiam, thank you so much. And our next speaker is Dr. Telma Costa from the Cervical Cancer and HPV Research Stream at the Daffodil Centre. And, oh, here you are. Come on up. And Dr. Telma Costa is going to be talking about Timor-Leste country co-design process. Thank you so much.
Thank you, Jacinta, and welcome everybody. My name is Telma. I'm here today to talk about the EPICC program. EPICC stands for the Elimination Partnership in the Indo-Pacific for Cervical Cancer, and about the co-designing process with Timor-Leste. This is our disclosures. And we know Australia is on track to eliminate cervical cancer on the coming years, but unfortunately, the same is not happening on many of our neighboring countries. And so a lot of work is yet to be done, including in the Pacific region. And the Daffodil has been pretty active in this global fight. And one of the good examples is this, the development of the strategic framework for cervical cancer control in the Western Pacific region, commissioned by the WIPRO. Another project that was already highlighted here today is the Eliminating Cervical Cancer in the Western Pacific. So it's an implementation project of screening and treatment of precancer lesions in the Western Highlands of Papua New Guinea and also in Vanuatu, which has been generously funded by the Minderu Foundation. Building on these previous relationships and knowledge and common work, we developed the EPICC program. EPICC is currently a 4-year DFAT funded, and the main goal is to support countries in the region to progress on the 3 pillars of cervical cancer elimination, with equity, with community involvement, and with sustainability. It will be implemented in 8 countries of the region, including in Timor-Leste. And just to give you an overview of the country, Timor-Leste is a lower middle income country where cervical cancer is the 2nd leading cancer among women. We know that currently there's no HPV vaccination program. We know there's no HPV screening program in the country. And we also know that treatment modalities are very, very limited. In terms of incidence, cervical cancer has an incidence of 14.8 cases per 100,000 women, which is very, very far away from the threshold that the elimination strategies advocate, which is 4 cases. However, we know that if Timor-Leste achieves the 90-70-90 targets over the next century, it will be able to eliminate cervical cancer by the year 2052, and more than 11,000 lives could be saved. So we hope that EPICC will support these achievements, and this co-design process has started a long time ago during the grant proposal phase. It started with virtual meetings that culminated in the first country visit in August last year. This visit was a scoping visit and allowed us to meet multiple stakeholders. We were able to meet with almost 20 different stakeholders individually, including the Ministry of Health. And we can see on this picture, Karen with the Vice Minister of Health, Dr. Fazio, after a very good discussion about cervical cancer in Timor-Leste and how we could support this elimination program. Then we also been fortunate to have in Australia some of the key leaders in the country that visit us. We developed a working session here in Sydney, and they were also able to travel to Canberra and also meet with DFAT. Already this year in January, we also were able to travel again and come back to Dili and proceed with this co-design process. And here, this photo is a really good example of a good meeting with civil society. So we were here at the ALOA Foundation. ALOA is an organization, civil society organization that supports women with cancer, and they are very, very keen to help us developing and implementing this program. Currently, we are convening a steering committee and a technical working group locally that will lead the next steps. We've been using multiple methodologies for this co-design process. So we've been doing several of meetings, roundtable discussions. And one key part of this methodology is the social learning and learning from observation, listening to people, being with people, understand what are the current needs, what are the gaps, so we can tailor our program to the best of their needs. And that's what we aim to do. And that's why it's so important to spend time with people, including in country. However, it's not an easy process. It's a very complex. We have to be aware of the social, political, and economical context, which is quite different from here in Australia, and also the cultural and behavioral context that it's also different. So we have to tailor, we have to understand, and we have to be led by country to develop and implement this project. But it also opens a lot of opportunities that will aid this program to succeed and to be sustainable even after the funded has finished. So it will be a program for Timor, led by Timor. And this is my last slide. It's a picture of a flyer that I found when visiting ALOA. It's written in Tetum, so their local language, and it basically is translated like this. So, cervical cancer, although it is a serious illness and a threat to life, good news is that it can be prevented and treated by early detection. And I leave with this message of hope, and let's try to support Timor-Leste eliminate cervical cancer. Thank you.
Oh, thank you so much, Telma. And yes, what a message of hope. It is so important to know about that kind of work going on. So thank you so much. I would now like to introduce Dr. Kate Dunlop from the Melanoma and Skin Cancer Research Stream at the Daffodil Centre. Thank you.
Thanks, Jacinta. Australia has the highest incidence of melanoma worldwide. What if we introduced an organised screening program for melanoma in the healthy population? I mean, those people who have no concern about a skin spot or don't have any history of melanoma. However, how would you feel if that program advised those at high risk to screen more frequently, but those at low risk to perhaps not attend screening at all? I'd like to present our research on key stakeholder views on that approach, a risk-tailored approach to melanoma screening in the population. Firstly, just what is risk-tailored screening? The current evidence is insufficient for a population skin cancer screening like we have for breast, bowel and cervical cancer. However, a risk-tailored approach offers a promising approach to melanoma screening. So it tailors screening to the individual risk. And the key is that it focuses on those most likely to benefit while aiming to reduce harms from screening for those at low risk. And also we have melanoma risk prediction tools validated in the Australian population. What's important is acceptability by the end users of this, being GPs and being the general community, is crucial to successful implementation. So we conducted semi-structured interviews with key groups, and we asked them how acceptable they would and how appropriate did they think a risk-tailored approach might be to screening. We interviewed the general public, 40 people, and 20 GPs from the Melanoma Genomics Managing Your Risk study. And I interviewed key informants who are experts in melanoma, 36 in a separate study. And by key informants, I mean national and state policy experts, consumer advocates. And by consumer advocates, these are people who have the lived experience of melanoma, but they also are leaders in the consumer space or experienced advocates. Also, I interviewed health professionals and researchers, and I analysed the first two interview studies by thematic analysis and the last one by a framework. So we collected a lot of data in this enormous number of interviews, but there were some common themes. And most importantly, the first was we found that all groups found that risk-tailored screening was acceptable in principle, and there was support for increased screening for higher risk. But there was some reluctance expected to reduce screening frequency for low risk. Interestingly, not much from the general public, but more from the GPs who were concerned about their patients, and also a couple of policy experts had some reluctance around this. This, of course, also fed into a concern about potential for public health messaging to cause confusion, and highlighting to us, of course, the importance of targeting public health messaging. Many noted a need for pathways for people at low risk, therefore, and to engage all stakeholders, especially GPs, in planning. I'd just like to share two good quotes from the consumer groups. The first one was from a gentleman in the general public when we asked him how, if he was deemed at low risk, how he would feel about being advised not to attend screening at all. And he said, probably I'd feel better if I at least had one screen, and then I might be more happy to go along with it. The second quote is from a consumer advocate, very experienced in this field, and experienced also in participating in research. And he was far less concerned about the frequency of screening and more about getting the message right. He said, I mean, at least people know what they're up against. At the moment, many people don't know anything about getting skin checks. So I think tailored screening is brilliant. I'm all for it. And our current work in melanoma continues. We aim to synthesize these findings to inform policy and possible implementation. There's modelling underway in the Daffodil Centre. Professor Anne Cust and Professor Monica Janda from University of Queensland convened a national melanoma screening workshop last year to discuss possible design components for a pilot trial. And we're currently conducting a questionnaire with key stakeholders. You never know, it might come across your desk. We'd like to thank the study participants because we had so many interviews. Thank you all for the opportunity, and I look forward to updating you on the progress.
Thank you so much, Dr. Kate Dunlop. And our final speaker in this section of the afternoon is Dr. Nicola Meagher, and she's from the Ovarian Cancer Research Stream at the Daffodil Centre. She's going to be speaking about engaging with consumers in ovarian cancer research. Dr. Meagher.
Thanks very much to the organisers for the opportunity to speak today. I've decided to really kind of focus on the theme of today, engaging with consumers and community. And I'm calling this presentation The Why. So thinking about consumers in ovarian cancer research as really being the why we do what we do. Many of you will know about ovarian cancer, but just a bit of an overview. It's a devastating disease. Less than half of women survive beyond 5 years. Unlike many of the other cancers and much of the brilliant work that happens in the Daffodil Centre, unfortunately for ovarian cancer, we don't have an early detection test, we don't have a screening test, and there are limited prevention strategies available. For decades, it's been a one-size-fits-all approach to treatment. Thankfully, things are shifting. There have been developments in publicly funded genetic and tumour testing, and we now have a new treatment, PARP inhibitors, and this is starting to shift the outcomes for women with ovarian cancer. One of the things that I'm very driven to do is to ensure that there is equitable access to this testing and treatment for all patients. This is a little, that's given away a little line there, but that's okay. Focus of my research overview. So some of the things that I focus on in my research are examining publicly funded genetic testing and treatment practices for women with ovarian cancer, including those inequities in access, and trying to project patient outcomes and costs. Using large epidemiological data sets through international consortia, such as the Ovarian Cancer Cohort Consortium, to explore a role for aspirin within the clinical management of ovarian cancer. And then also examining differences in ovarian cancer risk and survival by racial and ethnic groups. So as you've seen, the ovarian cancer community, we're very lucky. We've got a small group, but they're a very feisty group of consumers who work with us along the way in addressing all of these questions. And I just want to come back to the why and talk to you about one of our wonderful consumers, Jacinta, another Jacinta. So Jacinta was diagnosed with ovarian cancer in late 2019. At that time, there was no publicly funded testing available, so she paid privately for her testing. And thankfully, she discovered that she was eligible to have access to PARP inhibitor treatment. So after her surgery and chemotherapy, she went on to complete 2 years of that maintenance therapy, and she's now approaching the 5-year mark this year. But during that time, as well as battling with her own disease, she's dedicated many, many hours to help researchers and to advocate for her community. So who our consumers are, they are a force to be reckoned with. They're embattled and they're fired up. Ovarian cancer is rare. It's not really talked about as much as some other cancers. The treatment is fairly brutal, and so it's created a really strong group of very passionate advocates who really support each other. There's a teal sisterhood. They meet for lunches. Sometimes their sisters aren't there at the lunch table because they're too sick. They lose them. It's a very, very powerful group of women. And I just wanted to highlight a podcast which is really worth listening to called On the Down Low, speaking up about ovarian cancer. So Jacinta is actually one of the voices on this wonderful podcast, and they won an award in 2022 for Best New Podcast. It's really worth a listen. So they're inspiring leaders and they are making meaning of their trauma. And now just sort of to reflect personally on the impact of the consumers on my research, there's Jacinta and another wonderful consumer, Jill Stannard, who's also involved in our community panel. That was at the New South Wales Cancer Conference last year. So working with consumers, I think, brings purpose and meaning. So beyond thinking about numbers in a data set, we're thinking about human beings. They offer us a lived experience to the questions that we ask in our research. They hold us to account. So I've had conversations with our researchers, and when I'm trying to articulate what I'm doing, I've been held to account to say, who is this for, to really help me try and formulate questions and think about what we're doing, and again, the why. They support us in our grant applications. They read our grants for us. They give us feedback. I had a conversation with Jacinta last week about a grant application. And, you know, as researchers, sometimes it's very hard for us to really fully articulate the importance of what we're doing. And I struggle with my language. And she just said, Nikki, go for the jugular. This is important work and you need to get that across. And that was really powerful advice. And then finally, and very importantly, they're our cheer squad as well. They help us in the highs and lows of the research journey. So that's all from me. I'd like to thank you. Big thank you to our consumers, all our colleagues at the Daffodil Centre and funding supporters as well. Thank you.
Thank you, Nicola. That was fascinating just hearing about the role that consumers play in cancer research, which we're going to discuss more now in our panel discussion. So let me introduce our panelists, and when I introduce you, feel free to come and join the chat show we've got going this afternoon. So the topic, as we said, is involving the community in our research. First up, I know he's known to many of you, Mr. James Butler OAM. James is a long time. James, would you like to take your seat when I intro, or you want to wait? Up to you. It's like a sense of occasion. James is a long-time cancer survivor and is a consumer representative and long-time advocate for cancer patients and related issues. He's negotiated many issues regarding services for cancer patients with decision makers in the health services. He's the chair of the Daffodil Centre Consumer Panel, which we heard a bit about today, and the Cancer Council New South Wales Consumers in Research Review Panel. He's been a board member of Cancer Council New South Wales for the past 9 years and was awarded an Order of Australia Medal in 2021 for services to people affected by cancer. Professor Anna Fazio AM, feel free to come up if you'd like to, Anna, or you can wait. She has a long-standing commitment to translational research with an emphasis on improving treatment outcomes for women with ovarian cancer. Many titles she has, and they include co-lead ovarian cancer research of the Daffodil Centre, director, the Centre for Cancer Research, Westmead Institute for Medical Research, the head of the Gynecological Oncology Research Laboratory Centre for Cancer Research, Westmead Institute for Medical Research, and it goes on. Professor, we'd be here all day if I kept going with that. Professor Alexandra Martinuke. So Alexandra leads the Equity in Cancer Care and Outcomes Group at the Daffodil Centre, and she's a professor of epidemiology at the University of Sydney. She has extensive expertise in epidemiology, health systems, and services research, implementation and evaluation of complex interventions, Indigenous and global child health. Prior to becoming an epidemiologist, Professor Martinuke worked in paediatric oncology at the Children's Hospital of Western Ontario, and Associate Professor Meaghan Smith. And Meaghan is a lead researcher in the cervical cancer and HPV stream at the Daffodil Centre. She's particularly interested in optimising and successfully implementing cervical cancer prevention at the population level and in different population subgroups, considering efficiency, equity, and communications. Let's not forget about our final panel member who is beaming in, Professor Chris Baggoley, AOFAHMS. He's on the screen there from Adelaide. He's coming to us. Chris is an Australian doctor, Deputy Chair of the Australian Pancreatic Cancer Foundation, and Chief Medical Advisor for Calvary Care. He held the position of Chief Medical Officer of Australia from 2011 to 2016. And was awarded an Order of Australia Medal in 2013 for services to medicine. Chris was diagnosed with pancreatic cancer in 2019, so he can also speak from that patient perspective. So we are going to have a little chat here, and I have some questions for our panel. And if you have questions, we're going to give you some time at the end. So please store those up. Just bringing my phone down here for the timing so that we don't chat all day, because we could. We've also had some questions sent in from people at home on Zoom, so we'll try to get to as many of those as we can. All right, James, I'm going to start with you. Is that all right with you?
Absolutely.
Feeling ready? So you are James Butler, one of Australia's most active and experienced cancer consumer advocates. It sounds like you've been doing that for a very long time, turning your own, I guess, cancer diagnosis into something positive. So I wanted to ask you, first of all, what motivates you to be involved in this sort of work as a consumer rather than just being done with it once you've been treated?
Yeah, thanks, Jacinta. You mind if I sit up straight? I'm going to fall asleep if I sit.
Chairs, aren't they?
So motivation, I suppose, is something that we just heard a lot of this about the research. I mean, that's motivation itself for anybody to become involved. But my motivation, I suppose, is really simple for me. I'd always been involved with something or other, and usually ended up in a leadership role of some kind. So when the cancer came calling, I suppose it felt natural to become involved some way. So after my first diagnosis, I thought I'd better have a little break before I felt the need to become a volunteer in some way. And so after that initial experience, I probably needed to have a little bit of a spell. I had a young family. And then I was in, after some serious intensive cancer treatment, I was in remission for 4 years. And then my cancer recurred. And at that time, I think I felt it was time to actually get involved with something. When my cancer recurred, the treatment that was available to me was not available the first time. So research was at work. So I then decided that I need to, after my recovery from that period, I decided I better become involved in some way. So I got involved in a few things, one after the other, usually one thing after the other. Then I got a call from Cancer Council, and I had this call a few times before, so I knew the voice and I knew the number. So I suppose they said to me, James, we're doing this new thing at Cancer Council now. We're involving consumer research, and we have a consumer panel that will review applications for research. So I thought, well, this is something I really should be involved with. And I thought, yeah, well, I'll do it. So I did the training, and then I had a thought, is this really something for me? I'm just a normal knockabout bloke. So anyway, I did it, and what I saw and what I learned from not only becoming part of the panel, but also engaging with researchers, because part of the process, each researcher, when they put an application to Cancer Council, they need to have consumer involvement. So I became involved in that way, and meeting those researchers was just an incredible experience, and gave me the really, I suppose, the impetus to really get into this kind of work and become involved with the consumers. It's one of the most enjoyable, if you can call it enjoyable, work that I have done in my experience as a consumer, as a volunteer. So it's one of those areas that when being involved like that, you also realise the type of people you're dealing with, you're working with, and we've seen and we've heard from plenty of people today, and ongoing, how kind of special people they are in what they do. So in terms of what does the consumer contribute to the research process, I suppose, put it simply, it's a sort of adding the human face to the researcher. We can probably stand around, or most researchers will do a little bit of that work and they'll carry on with the work, and it's brilliant as it is, it's brilliant work. But very often, I think they need to realise, or have to realise, and they do realise, that at the end of that, and probably not even born today yet, are people walking around could be beneficiaries of that research that they're doing. So I think that's probably the main thing that we can offer to research. We also, in engaging with them, we understand where they're coming. We engage with great respect for one another. And it wasn't always the case. Researchers and clinicians generally, some clinicians still don't understand the benefit of having a consumer involved. But that's one of the great things about engaging with them, because they understand where we're coming from, and we understand where they're coming from. And again, that mutual respect is very, very important. I think in more recent years, since I've become involved with the Daffodil Centre here, and the work that I can see is happening here, and Karen and our team are just so brilliant in what they're doing, and have really reached out to have consumers involved. So that's where my role comes from, in terms of being involved with the panel, and also engaging from that panel to the steering group as well. So that's where I come from, really, as a consumer in research. And I think as I get those extra couple of years older, maybe I've got a couple of years left, who knows? Anyway, thank you again. And by the way, thank you, Sarah, for your kind words as well earlier on. Appreciate it. Thank you to everybody. Bye.
Yes, and it occurs to me, and I'm sure many others too, that you talked about the benefits for the researchers,
Yeah.
but it also, I imagine, is very beneficial for you as a consumer. This is a word I've never heard before in this context, but as a consumer, to be taking some advocacy for your treatment, to be able to speak up and say what you think needs to be done. Is that also a
Yeah, I think
something to
sometimes, I
consider?
mean, with some of the researchers I've worked with, it's something often as simple as saying, what do you think about that? And I can't remember how many times it's happened, but researchers, very, very serious senior researchers, have said to me, oh, that's good, I've never thought of that. So
My work here is done.
yeah. It's not because
Wonderful.
I had the better idea than they did.
Yeah. Well, it's a different
I
perspective.
probably thought myself I did. But no, so it is very important to have that involved. And as I say, at the Daffodil Centre here, I can see from the people I'm working with, Karen and her team, as I said before, and I have to mention obviously the lovely Eleanor who created the consumer group. Thank you, Eleanor.
Thank you so much, James, for your insights there. We might return to you if we have time, and there'll be questions from the floor. Professor Anna de Fazio, you work at the cutting edge where biological research is translated into delivery of care tailored for these individual consumers. So I wanted to ask you, as a predominantly laboratory-based researcher, one of those people that James was talking about before, what types of interactions do you actually have with your consumers in your research projects?
Yes, look, I've had the privilege of having lots of interactions with consumers over my time, in many different ways. So we've already heard from Nikki so articulately earlier how we have researchers that are involved, consumers that are involved in each of our research projects. So one or two that will be assigned to particular research projects that we will interact with over the course of that project. But I guess I'd like to just sort of to bring some examples of other types of interactions that we've had that might be both formal and informal with consumers. So I also I have meetings with our patient support group, so the gynae support group at Westmead. So that's a group of about 20 or 30 women who come together on a monthly basis just to chat and support each other. And I'm often invited to come along. And I sometimes use that opportunity to bounce ideas from this group of patients. And I just wanted to give you one example. We had a project where we were trying to identify why individual patients eliminate chemotherapy from their body at different rates, because that might affect how well that chemotherapy works. But when we looked into the methods that we'd need, we were going to ask the patients to have multiple blood samples taken over the course of the day, and then come back the next day to the hospital to have another blood sample taken. And I frankly I felt very uncomfortable asking the patients to do this. I had all sorts of crazy ideas of putting a centrifuge into the back of the car and taking it to their home, you know, so that they wouldn't have to come back in. And I thought, oh, look, I'll just ask these our group to see, what would you think if I asked you to do this? And to a person, they said we would do it in a heartbeat. Absolutely, we would do it in a heartbeat. So we were able to undertake this fantastic project that I actually wouldn't have had the courage to do if it wasn't from the feedback from those patients. So that's sort of at a local level. But I've also had the privilege of working with consumer organisations at a national level, and so they're looking at equity across the country, and certainly they are the ones who will hold you to account if they're in the part of the country that hasn't got access. So certainly from a national level. And I've also had the great experience of having an international interactions with consumers. So we have a very, as Nikki said, feisty consumer who was a consumer in a really trying to bring a focus to a very, very rare type of ovarian cancer. It's a rare type of ovarian cancer that can actually occur in young women, sometimes 17, 18 years old, so very young. And she felt that, that because it was so rare, it was being ignored. So this feisty consumer has brought together an international group of researchers and clinicians working on that cancer type, and we've formed an international consortium really off the back of the enthusiasm of this consumer, to the point that at one stage she even had billboards in Times Square in New York and the centre of London, sort of up there on the big billboards to really bring a focus of attention on this rare cancer type. And so I guess really one of the things that I've had over my time is that the consumers really push us to do things beyond what we would have done. So really to ask those bold questions and to do research that was bigger and bolder than we would have done if it had really been left to us. So really, I've really appreciated, the fantastic input that they've had at all of those different levels.
What did those billboards say?
Oh, they had wonderful, big, huge photos of a whole raft of the women who had low-grade serous ovarian cancer, which is what this rare subtype was called, and really, making sure that people understood that this is a thing, because most people who are diagnosed with this disease have never heard of it. And they can't believe that they're 25, 26 years old and are faced with this life-threatening disease that they've never heard of. So
I was going to ask you about some of the positive impacts that consumers have had on your research. You've sort of touched on that, but would you like to elaborate?
Yes, so certainly positive impacts. I actually think some of the biggest projects that we've done have been off the back of input and enthusiasm from our consumers. In particular, again, Nikki brought up a point about discussing a research grant. So I can remember at one point we had that disappointing news that we didn't get a grant, and everyone in the room who's a researcher will understand the effort that you put into putting in a grant application and how devastating it is when it's not successful. And I had one once where I was ready to, I thought this won't fly, I was ready to give up, and it was only from the consumer saying to me, no, it's really important, you really have to try again, let's make it bigger and better. And so, and we ended up being successful in the grant, and have been doing a project that has really had impact on individuals. So, and really that's from the benefit of that enthusiasm that was brought to us from the consumers.
You went for the jugular.
We did.
Yeah,
we did.
And which is fascinating hearing all of this, because you would assume often consumers feel intimidated by the medical profession and feel that they don't want to be a nuisance and get in the way. So this is this is really important.
And I think it's really important. I think that's why we really try. That's why I wanted to bring up the point of speaking to the consumer group, because it's one thing to have one or two consumers in, let's say, a panel where you might have a lot of researchers, and sometimes they might feel intimidated and not want to speak up. But when you turn the tables and you're the only researcher and there's plenty of, that gives them a little bit more courage, if you like. So we certainly do make sure that we make it a very comfortable environment for them to really tell us how they feel.
So fascinating. Thank you so much, Anna. And Alex Martinuc, if we can turn to you now, your work focuses on the crucial cost-cutting theme of equity. Can you share any concrete ideas on how we might involve community in addressing cancer care disparities?
Yeah, sure. I always like thinking in stories. So kind of going on the theme of how important consumers are in changing the direction or having us go for the jugular. Most of the work I've done that has gone on to have strong impact has actually been from the beginning. a community member or a consumer. When I think of consumer engagement, I think very broadly because I'm systems person. So I think it's the patient, certainly the family, but also, you know, health staff, decision makers, and so on. So I know some of my initial work in Malawi, when childhood cancer, that's my interest area, and in global health settings, when childhood cancer was not seen as a global health topic. It was a topic for high-income countries, and it was not to be discussed, really, and in part because the numbers didn't appear to be there, partly because kids were dying and never being diagnosed with cancer. But I remember a kid in Malawi came up to me, and I was working in Malawi on HIV and transmission of HIV from mom to baby, and someone said, well, what about you know, kids with cancer? We've got some kids with cancer here, but we can never you know, we can never do anything about it. Policymakers, advocates, the hospital staff, they don't want to, you know, and management don't want to hear about it. So that was one of our first papers, which was around using some modeling, economic modeling, about what would it look like if we did try to treat some of the cheaper, you know, pathways in terms of treatment, diagnosis treatment for some childhood cancers. So that was a really important piece that came from, you know, a consumer, so to speak, a community member. And I was just thinking of other work that's come from communities, also that's gone larger than just them, which I think is so important. Is a few years ago, I was working with my PhD student, Neha Faruqi, who's was a UCID PhD student, now works at School of Public Health. And we were working with our colleagues in India, looking at how families accessed chemotherapies for childhood cancers. And it was so essential because we hadn't realized, really the system hadn't realized, that families were asked to go find their chemo. They were given the list, and then they actually just walked around all day in the hot sun in the middle of Delhi to pharmacies, you know, do you have this? And families often didn't even know what else to ask, in what formulation, what dose, how long would it last, were they out of stock now, but it would come in later, and so on. And so this body of work, we wrote this up, and it actually has become quite a large body of work, a platform on essential therapeutics and diagnostics by the WHO Collaborating Center for Childhood Cancer. So just two stories, I guess, of where patients, consumers, families have really led us down a track of what is, I think, large impact.
Yeah, that's a very potent examples there. And I wanted to ask you how we can encourage decision makers to take meaningful steps towards involving community to improve equity in cancer care.
Yeah, I think I'm originally a psychologist, and that's what I used to do in pediatric oncology. So I always come back to, even just in my daily practice, not necessarily research, but I come back to the knowledge, attitudes, behavior wheel, because we're all humans and we all run on that wheel. And I think decision makers and consumers, and us as researchers and clinicians, some of us, we need to gather knowledge around how to include consumers, community in understanding where the inequities lie. And those are very nuanced. I mean, we know some of the simple ones, right? Indigenous Australians, lower access to care, and so on. But there are nuances within each of these. And then we need to change attitudes. There are a lot of stigma around various cancers that certainly community members can assist us with, but also in changing the norms of thinking. So in my area of interest, which is you know, closing treatment gaps for kids with cancer in LMICs or all global health settings, is changing the mindset that childhood cancer is important for all children, no matter what country you live in. So that's that attitude piece. And then the behavior piece for me is the action. Let's see real change. And to me, I'd love to see, you know, real financial resource and other resources put into real change and make that accountable. So when we say we stand behind equity and including consumers and community, and that we do that in a resourced way as well. And I think that's where we'll stand out, and we already are. I mean, this is a great example of that. And I've thought of Daffodil and how Daffodil can help share this pathway for others. And I think and gather evidence about how we're doing this well, how we're engaging with the community well to get the best outcomes. And I'll leave on a nice little Indigenous quote that I've always liked, which is something like this, which is the log which is dropped on the river to be crossed is left behind. Which is true in a practical sense. You don't want to pick the log back up again because it's just too heavy. But it makes me think of Daffodil, is that if we trudge through this space, we can learn a lot about how to engage consumers, and that comes to the practical nature. A little small question we came up with. So when we're engaging consumers in a global health setting, if we're paying consumers in Australia to reimburse them for their time, for instance, to travel to a focus group, well, what do we do in a global health setting? We should reimburse them also, but in what dollar amount? Is it the same as the Australian participants? If it's so there's these little nuances that I think as a Daffodil Centre we can grow and learn together and share this knowledge to better engage consumers going forward.
Thank you so much, Alex. Chris, we haven't forgotten about you. We'll be with you in just a moment. We're just about to ask a few questions of Associate Professor Meagher Smith. So, Meagher, reducing inequity and providing tailored screening options is at the centre of Australia's plan to be the first country in the world to eliminate cervical cancer. Could you tell us how consumers in the community are involved in the supporting choice for cervical screening program of the work that you co-lead?
Yeah, I'd be very happy to. It's one of
I'm
my
sure you are.
passion projects. Yeah, so the choice that's being referred to there, supporting choice, is since July 2022, people who are eligible for cervical screening, everybody who is eligible for cervical screening should be offered the choice between whether they would like a clinician to collect their sample with speculum exam, the usual way it's been done for decades, or to collect their own sample using a long swab. It's a bit like a COVID swab. People are familiar with using it for STI testing or strep B testing in pregnancy. And the context there is that cervical cancer, I think it's come up before, it's a highly preventable cancer, but the downside of that is that it's also led to a lot of inequities, and that people with good access to prevention, in particular cervical screening, have done very well out of those great services. But a lot of people have had more barriers to accessing those services. So self-collection was introduced in Australia about 6 years ago as a method to try to reduce some of those barriers for the groups who have barriers to screening. But it was highly restricted. It was only for people who are very underscreened. And unfortunately, it really failed to achieve its full potential and its objective because it was so restricted. People didn't know it was available. Certainly the people who most needed to hear about it did not know it was available. So the thinking behind making it available to everybody is to say, well, this needs to be part of routine care. This needs to be seen as, the best clinical practice that a provider offers people choice. And so supporting choice is, I guess, about providing the evidence that needs to make it be part of routine care, because as you probably are all aware, sometimes doctors don't like to change. Sometimes they think that they know what the best thing is for their patient. And this is really putting some control in the hands of the patient. So yeah, it's about providing clinicians the information they need, the support they need, but also the patients and the community the information they need to make a choice. And so the community are involved in this sort of program of work, both as participants in the research, not surprisingly, but also as really key advisors to that work. So we've got sort of 4 pieces of work, and 2 of them directly involve consumers as participants. There's a very strong focus on that equity. Let's not just make self-collection part of routine care so that the people who are screening anyway and are having a great time preventing cervical cancer, it needs to get to those people who have been missed in the past. But I think a really great experience for me has been working with my collaborators at the University of Melbourne to develop a consumer and community advisory panel. And we deliberately include the word community there. It's not just consumers who've used cervical screening, but the community who it's available to but may not have used it yet. And an advisory panel, it's not a group where saying, you must come to a meeting where we will seek your thoughts and inputs. It's about asking them, how would you like to engage? Some people just want to review documents. Some people really like coming to meetings and discussing. Some people want a small group conversation on an area of their interest. It's not, they don't want to be involved in anything and everything. So there's 14 people in that. They were directly recruited. We advertised for them through a lot of networks of partners, community organisations. They're a very diverse group. Very few of them have had cancer. So, and again, that was deliberate because in screening, we're just trying to talk to people who may not really be even thinking about the risk of cancer. So we wanted that perspective. We wanted diversity in terms of, you know, culturally and linguistically diverse people, people who live in rural and remote areas. So that has been incredibly helpful to have that diversity of experience. As Alex mentioned, we pay them depending on what they're able to contribute. But I guess the net effect of this is, you know, they have fantastic benefits on our research, and they are a wonderful asset that we're only just starting to use because we're in the data collection phase. I think when we get to the synthesis and the dissemination, they're going to just provide even more value, but it's a really substantial investment, both in time and money, to have put this together. And I know that even for this grant, when we originally put it in, it's very hard to find consumers on the sort of grant timescale. You really want to involve consumers, but you need to have the relationship there, or you need to have a way to connect with people. Yeah, so that's been valuable out of this experience for me.
And I'm so glad you went into that detail, because I think it's one thing we've heard about today, the importance of having consumer advocates and consumer input, but you've explained that that's not as simple as that. There's a whole lot of how is it done and how is it equitable and so on. So that was a really interesting example. Thank you so much, Megan. Professor Chris Baggoley, thank you for your patience. I don't know where to look. You're up there. All right. So you have a CV like no one else, so I'm not going to go through it all, but you've been a senior health services administrator, and now you're a cancer consumer, I understand, 4 years post pancreatic cancer diagnosis. So I think it's important to ask you from that perspective, how can the research that community do more to take experiences like yours to deliver better outcomes for the entire community?
Well, thank you very much, Jacinta, and thank you, everyone. I do apologise. I'm the only person I can see in the room there, and I'm larger than life, and I'm bad enough just regularly in life. So apologies for that. I was going to be there in person, but I got a chest infection just prior to Easter, and another plane trip would not have been good for me. So, and I do want to congratulate the Daffodil Centre on their 3rd anniversary. So that's good. My involvement with cancer really came from losing friends and colleagues with pancreatic cancer. And that was the one diagnosis I just never wanted in my life. Regardless of my wants, I was diagnosed with pancreatic cancer in January 2019. So miraculously, I'm at 5 years now. I didn't think I'd get there. My medical background has been in emergency medicine, safety and quality. Became public health when I was Chief Medical Officer for the Australian government, just the one prior to Brendan Murphy, and thank goodness for Brendan and him taking on COVID. So got the diagnosis out of the blue, didn't bother Google, but I did go to the optimal care pathway for pancreatic cancer, and that was produced in 2015. And of course, people here with Cancer Council and Cancer Australia be very proud that they endorse these pathways and have provided very valuable and dispassionate and evidence-based information for me. I've become aware of it because I became co-chair of the National Cancer Expert Reference Group, which had been chaired by Jim Bishop. And you'd all know Jim, I think who was the CMO prior to me, but went abruptly to head up the Victorian Comprehensive Cancer Centre. So I had that document come to the EPICC, and so something I could reach to. I didn't expect to survive for 12 months, but I did. I was able to have surgery and chemotherapy. And following that, in February 2020, I was asked to attend a gathering in Parliament House on pancreatic cancer, and I had a chance to give my few minutes experience on that, which did include the advice from my oncologist. When I asked him at the end of my chemo, I said, well, what's plan B? I'm up for clinical trials. And he said, don't bother. With pancreatic cancer, there is no plan B, which didn't make me very happy about that. So I thought, well, while I can, I'm going to do as much as I can to support people with this disease, of whom 80% are dead within 12 months. By the way, pancreatic cancer is now the 4th highest killer of cancer killer in Australia. So, and rising. It's not a good one to get. So I joined PanKind, which is the Australian Pancreatic Cancer Foundation, based there in Sydney, because I caught up with some people there, and they asked me to join the board and taken on the consumer role on the board, on their scientific advisory panel, where I'm mostly bewildered with the depth and extent of the science, which has not been my background, but certainly not intimidated. And the panel are very highly capable people, certainly don't act in an intimidatory way. And through that too, I've accepted invitations to take part in research. I have, as in responding to questionnaires for research that will be published, and been often taken on roles as an associate investigator as a consumer. And I think that is a really important role. And we've heard comments previously on that in this discussion, how consumers every now and then at least I could come up with a bright thought from quite a different perspective that makes people just stop and think and occasionally change direction a bit. And an associate investigator on application, but also on research grants when they're funded. And I'm certainly willing to take part in clinical trials for myself if and when it becomes necessary. And I'm sure I have learned there's certainly more than a plan A, but not that many of the others are particularly effective as yet. And one thing I have found is that patients and their relatives, and particularly my area, because patients, pancreatic cancer, don't have the opportunity often to do more than just deal with their own survival and their own journey, to then take part in research, but their carers and family certainly are willing to do what they can. And Anna's thought and comment on that really struck a chord with me. And if only happy to take part in response to questions about their experiences. And of course, research is much more than the science of the cells, I think. It's also about the soul and the psyche, and there's so much to learn, engaging consumers about what they're going through. So, and also I found that carers and researchers, carers and patients are willing and just doing something to raise much needed funds so others can do the research that can make a difference for others following them. So that's been my journey. It continues. I'll keep doing this as long as I can. I'm very well at the moment, and very willing to keep contributing as a consumer. As I say, someone that doesn't get intimidated.
Wow, it's such a fascinating perspective, isn't it? To have someone with your medical expertise and knowledge and background, and then now coming from this perspective as the consumer, as we call it. Another question for you before we let you go, Chris. How could we do more to take the individual experience that you're talking about, to take that experience on board when treating cancer patients?
Well, I think more questions could be asked of consumers, of patients, particularly those who are undergoing clinical trials, and to find out how it is going for them. How's their life being impacted by this trial? And it depends on the nature of the clinical trial and what are the outcomes that are being expected of it. But it can be, from what I understand and talking with people, what's going on in their heads, what's going on in their lives can be put to one side a bit by researchers who are very keen to see what happens to a life expectancy or a blood laboratory test. And that, I think, be much more valuable. As I say, it's more than the science of the cells, research into cancer.
I think that could be the quote of the day, more than the science of the cells. Such a great line. Thank you, Chris, and thank you to all of you. But we are going to throw open now to questions from the floor, as they say. So I'm sure there are many. If you have a question, just raise your hand and we'll get a microphone to you. I know people have them. They just don't want to be first. Oh, here we go. Oh, I thought you were going to ask a question. All right. We have a few up the back there.
Thanks so much to all the panelists. Megan touched on this point. It seems like if we're interested in equity, sometimes the people we most want to hear from are those who are perhaps not very engaged with the services or treatments or screening programs that we offer. So just wondering if the panel had any advice on how we reach those people who are, not the necessarily like strong advocates or very likely to sign up for these kind of activities, but the harder to reach groups.
Yeah, and I guess, as I said, Ben, we really had to go directly. We had to go with, so for example, we wanted some people with lived experience of a disability. So we went to Women with Disability Australia. Similar groups like that, where they're sort of more about the community and less about the cancer kind of side of their lives, I guess. I mean, particularly given we're in screening. So we were really fortunate to have groups like that who are willing to share the invitation. But yeah, I think, as much as we hope to get people represented if they had, not interested in screening at all, have lots of concerns, I'm not sure we were that successful, but I think we did do pretty well on the general diversity.
I'll just say where I've seen some I guess solutions work well is around community navigators. So in First Nations communities in Canada as well as here, often there are community navigators who may not be health profession trained themselves, but they obtain some training to become a community navigator. And as well in Canada, when I worked in the clinical setting, we had patient navigators, which I think we're familiar with that, but specific to sort of equity patient navigation, because of course there's patient navigation in terms of coordination of care, and that's important too for everyone. But then there can be also cultural or linguistic navigators. And I think that's where the ethics of deciding as a society that we want to put resources towards that to address equity issues is actually some of our main barriers in getting those in place.
Great. I think we had another question up the back there.
I think Chris was going to say.
Oh, I'm sorry.
If I can, and that's a really important question. How do you reach people who aren't advocates and so on? I think there's a very simple way. If there's, and particularly researchers and others who are interested in the outcomes, people with the cancer are being treated. And while they're being treated, they're often sitting in day centres, booked up to their chemo. Mine was 9 hours a day every second week. In fact, it went over a few days. And people could come and talk to them and ask about their experience. They're there. They're hooked up. And I don't think we make enough, we don't take enough advantage of the difficult circumstances these people are in, but to learn much more about them.
What a great point, Chris. Did I see another hand up? Oh, now we've got a few. I'm going to leave it to the mic guys to decide who's asking questions.
Thank you, everyone. You're bringing up beautiful points. You really are. And I love that there's diversity of thought and introducing a whole new spectrum into scientifically helping people. I'm just throwing it out there because we've got a lot of researchers here in the University of Sydney, and we've got another group of universities here that are involved. But wouldn't it be lovely to just throw out potential researchers, research material, and just let people go with it if it's possible? So has anybody explored, and this could quite easily have been the case, something like povidone iodine, which is your general betadine that we have in different concentrations used as a carrier, because iodine is extremely active. It comes in a tri-atom that is extremely active. It's part of the fluorescence. It's an amazing thing. And we get betadine anywhere. And that is a carrier to be able to take something as natural as garlic to heal with viruses and see if that can be taken anywhere. These other things like magnesium, that's incredibly beneficial for the body. And can that research just be thrown out there? We've got fantastic people in Australia with the ability to do research. And yeah, these are natural therapies. This isn't something new. This is out there. If you just research it on the net, you'll find that these things are magnificent. It's just finding the right combinations. And perhaps that can be done either through a flush, if that makes sense to some people, as dreadful as that sounds to us ladies, or it could be introduced through a Clarius ultrasound machine that is attached to a needle and intravenously put into us to see if that can perhaps heal. There's so many different options that we can do through natural therapies using our clinicians who have that knowledge to be able to do it properly. I'm talking about the proper doctors that could inject correctly. We've got fantastic medical imaging teams here. So there's so much that we can do in Australia globally at a much quicker rate with these fantastic researchers that we have.
I think that is a great, it's more of a statement than a question, but unless someone would like to, yes?
Yes, I'll take that on. So certainly we have done some research projects internationally looking at what, at some things that people just do for themselves. So whether that's drink green tea or do exercise or take aspirin or
meditation.
Yes, and in fact, those research projects have been really done very well. So really looking at what happens, once a patient is diagnosed, and looking at a whole raft of things of lifestyle factors and natural things in combination with their normal treatment. And certainly anything like that really needs the same rigor and research that we put to any of our treatments or any of our other experiments that we do. And it's been quite interesting to see where some of those areas intersect. Things that we do like smoking, for instance, and how that not only can give you lung cancer, but actually apparently can affect how well your immune system helps chemotherapy. So there's lots of interactions that can only be done with really well done research and really funding for looking at the point that Chris made, looking at everything to do with the patient when they're on a clinical trial, not only the drug, but everything else that goes around that. The difficulty is then, because a lot of work that has been observational, that next step of actually introducing some of those things into clinical trials can be very difficult. But certainly something we need to look at the whole picture.
Yeah, so thanks for introducing that. It's just the open-mindedness, as you say, and tuning in to the consumers rather than focusing on your research. We are running out of time here, so and I think we've got a few more minutes.
I rehearsed that.
Okay.
I've got a bad back and these chairs spring up when you take your pressure off them. Sorry. Quick question, mainly for James and for Chris. An interesting juxtaposition. I thought of this before the previous comment, but consumers don't always advocate for things that are supported by the evidence, but the worst thing we can do is to be dismissive of their views and beliefs. Do you have any advice on how we can maintain that engagement with consumers and to really value their input, including in areas where the evidence may never support their interest, but we should not be any less involved in the engagement with them?
James, do you want to answer that?
I didn't quite get all of it, Paul. My wife would normally say, put your hearing aids in, but I've actually got them in. I didn't quite get them in. Can you just repeat the end of it again, Paul, please?
Well, the importance of engaging with consumers, even those consumers who may have beliefs that will never be supported by the evidence, but we should still maintain and strengthen the engagement with them and try and get the balance right between, and of course, research is a never changing thing, evidence changes. So, I mean, I just know it from being involved in health communications for a long time. We you know, the area of alternative therapies, which has complex for a number of reasons, but and the worst thing you can do as far as the clinical practice side of it is be dismissive of those beliefs. So how can we engage with people, even if their beliefs may never be supported by evidence, to ensure that they have some sort of input into what we do?
So if you're asking, Paul, and again, I didn't quite get everything, but if you're asking, I think the ongoing process with the consumer, is that basically what you're coming at? Yeah. Yeah, it's very important to keep that engagement going, and it's also very important for the consumer to be able to understand why you're there, why you're actually doing this, or is this just something to tick the box? And I think that certainly in the past has been the case in some situations, and possibly still is. But I think once the processes are tidied up a little bit more, we get better at that. But yeah, I think it's important for both parties, Paul, to keep the engagement open as much as you can. And I think as time goes by, because consumers are often engaged in other ways with the cancer community, for want of a better word, they often hear and see other issues outside of the ones that you're discussing with the particular researcher. One of the things with consumers involved with research or involved anywhere is what they learn from other people. I personally have walked a journey with many cancer patients of all kinds, and in some cases right to the end. And the things you learn from that in itself are quite remarkable, actually. And it gives you great insights into not only what you're thinking yourself or your own experience, but other people's as well. Does that answer your question, Paul, pretty much?
And Chris, did you want to add anything to that?
Yeah, look, I think it's a really important question, and it comes back to having the consumer at the centre of everything we do, rather than the medical practitioners or the researchers. When you look at it, the person with the cancer, it's their body and it's their life, and it's often they're clinging to it with not much hope. It depends on the nature of the cancer, of course, and for some cancers, thank goodness, breast, prostate, there's a really marvellous set of opportunities for them. But it's important when people offer their thoughts and their perspectives and some potential remedies that they may want to take, that it is taken seriously, and for treating practitioners to look to see whether there is any evidence, if there's something going on elsewhere in the world. And again, probably because I'm coming from the background of pancreatic cancer, when you know that 8 out of 10 people have got it, know they'll be dead within a year, they're likely to want to take on a whole range of different options and to think about it, to talk about it. And the last thing they need is someone say, well, that won't work. There's no evidence. Sometimes there's no evidence because research hasn't been done into that, or that the evidence hasn't been brought to the attention of the practitioner. So it's about supporting and having constant communication. And if possible, I think, as long as there's no evidence that what might be being sought is going to cause harm, there's evidence that harm could happen and you can't really go ahead with that, then engage with and work with the patient is the best way to go, I believe.
Oh, what a wonderful point. I think we probably have time for one more. If there's someone who's really hankering to ask a question, just let us know. Great.
Thank you. My name's Jeff Cuff, and I'd just like to say that I think the panel's done a marvellous job and the topics that have been covered. When I walked in here, I was making a few notes, and 2 words I wrote down were empathy and be bold. And I was so pleased to hear those areas come out in the panel discussion. And I think that the consumer needs to be bold and brave enough to ask why and what if you could do this, or what if you could do that. I guess in the journey I've had in this area, that's always paid dividends for me. And I guess I've been fortunate because researchers have certainly listened to that comment and in fact changed some pathways in the research. The other thing is, I think the researcher or the consumer needs to be embedded in that research from go. It's not good enough to be there when there's grants involved. They need to be there in the development of the research itself. And I think of it because I'm very keen on the translational cancer area, and that needs to be really embedded from the wet lab, if you like, through to the patient. And so the same is of the consumer. They really need to be listened at in the design, the development of, and the end result, which hopefully is improved outcomes for patients. There's one area that I think in all the discussion that the consumer can really take hold of and needs to, and that is the question of quality of life for the patient. We're talking a lot about research here, which is great, but in that process, I think it's beholden of the consumer to really make sure that the quality of life for that patient is upheld regardless of the treatment. So I don't know if anyone would like to comment on that point.
Anyone want to comment on that?
Yeah, I think you're absolutely right, Jeff. But having said that, I think very experienced consumers like you and I, and quite a few other people, but a lot of consumers, particularly those who are just getting into the consumers and research area, probably wouldn't be up to that kind of level, or would have that kind of confidence to question on those kinds of issues as well. But certainly in time and with training, ongoing training, it can certainly be taken there. But I think at this stage, it's probably for a lot of consumers, it's probably a bit too far down the track. But I agree with what you're saying.
So we are unfortunately going to have to wrap up there because I know that you've got some celebrations to have for the 3rd anniversary of the Daffodil Centre. So we'd like to thank our wonderful panel, James Butler, Anna Di Fazio, Alex Martinuke, Megan Smith, and Chris Baggoley. Thank you so much, everyone, for giving a round of applause.